Hi, I'm Enista Smith, and alongside my co-host and friend, Jason Lembeck, welcome to Thrive Together. Thrive Together is a podcast sponsored by the Thrive Center at Georgetown University, exploring what it really takes to help children, families, and communities thrive. In each episode, we sit down with innovators, practitioners, funders, and community leaders who are building hopeful, practical solutions across mental health, disability, belonging, and systems change. We talk honestly about what's working, what's hard, and what becomes possible when we invest in prevention, accessibility, connection, and care. These conversations are rooted in the belief that thriving isn't something we do alone. It's something we build together. Today, Jason and I are so excited to speak with Mallika. Mallika Reddy Pajuri is co-founder and CEO of PsycheCare. PsycheCare is a peer coach platform that helps families take their kids home after a mental health crisis and actually keep them well. The model pairs newly post-crisis families with parents who have been through it themselves through telehealth coaching, daily text check-ins, and short-form video content built for the months between clinical visits. Earlier this year, Mallika and her co-founder, Hansho, were named 2026 Wesley Prize winners at Stanford for the work. And that, plus her own story of navigating a serious diagnosis as a young adult, is where a lot of today's conversation is going to live. Mallika, thank you so much for joining us.
Thank you for having me.
So happy to have you here.
Jason, it's a pleasure to see you and be reunited with one of our favorite humans, Mallika. Are you on the East Coast or the West Coast today?
Well, I'm on the West Coast, so I'm currently calling in from Dublin, California, hanging out with my parents, having a blast.
It's so great to be with you today. So as you both know, I'm a little bit of a hopeless optimist. And so I want to start today's conversation by asking you, Mallika, where are you finding hope in this moment? And what's your why in this urgent work that you do?
Yeah, what a critical question, especially in the year that we've been having as mental health innovators. I always go back to the idea that working in mental health is an inherently political act, and especially in a year such as this one, where there's so many cuts left and right to critical services for communities, it's really hard to find the moments of joy, especially as an early stage innovator who has only been working in the space for the past couple of years. But what really does inspire hope is seeing folks who have been in community for decades doing this work on the ground who continue to speak up and advocate for the communities that they serve. And I have a great example to share today. So our company went out to Minnesota last fall, and we were on the ground building up partnerships with clinics. And immediately as we left the state and got really excited about the multiple clinics that we signed as partners, there were pauses to certification for the service that we were providing. And we didn't know what to do, what the next steps were. We were frantically trying to figure out if it was worthwhile for us to even continue to focus on Minnesota. And in that thinking, we continued to call our partners and ask them what was going on. And especially in the escalation of ICE raids and pauses to certain programs, we kept hearing how tiring and tumultuous it was for these providers and owners of practices on the ground. However, we're constantly inspired by our partners because they constantly show up. They're posting on LinkedIn or sharing what it feels like to be on the ground in these clinics as clients find it harder and harder to make their way in the clinic. And as the state continues to, ask questions and, assess the quality of these programs, even though they have been impacting communities for decades. And I feel particularly inspired and hopeful when I see these leaders who won't back down, and will do anything in their power to continue serving families. And it gives me a lot of hope as an early stage innovator. This journey is going to be a long one, and there are going to be turnings of the tides from time to time, but being able to collaborate with individuals who continue journeying towards a North Star, which is impacting communities, it really keeps us grounded. And honestly, as we've continued doing this work, it really has turned into my why. It's the community that we've built in delivering the services. I think when we started, we had a very clear mission of how we wanted to impact families. Um, and it was really focused on this relational health approach. And, it keeps us going to this day. But really, what keeps this work alive in the midst of our own crises as entrepreneurs is the community that we've been able to build. It's the accelerator programs and the advisors that continue to offer answers in moments of relentless questioning from our end. It's the community partners that continue to implement when they're facing similar challenges to us as providers of care. It's everyone in between. So it's just this mental health continuum, which includes the patients and their families, but expands way past that, that really continues to be our why today.
I love that, and one of the things I love about getting to be a small part of your journey through the Thrive Fellowship is watching you not only get energy and hope out of partners, out of fellowship and community, out of family critically and supporting families, is that you also, as a team and as a person, have channeled some of your own experiences and some of your friends' experiences navigating the system. And that was, I know, kind of an early spark for why you got into this work. And thinking about that, I wonder if you're open to it, like maybe thinking about the day, or if it wasn't a specific day, a conversation or a moment that really catalyzed you into doing this work.
Yeah, definitely. And I think, especially because we have longer than 30 seconds for me to explain this, I can actually get into the nitty gritty of the story here. Because traditionally I say A happened and then B happened and then Psyche was born, which is honestly not the true story. It was a multi-year effort. And when I met my co-founder online, it was actually the beginning of my chronic illness journey. And I'd recently been diagnosed, and I knew that I was curious about patient advocacy solutions and family advocacy solutions, but I didn't know exactly how that would take shape. Would this be a project outside of school? Would I just allocate a few hours a week to this? Will this just be a 1 to 2 year effort and then I ramp it down? I had no idea. And it was quite interesting that our journey in exploring ideas and exploring what the company could turn into was, paralleled by my own personal journey of my chronic illness getting worse before it got better. I think it was month 6 of working on Psyche that I actually had to escalate my care and start going to emergency rooms and fly across the country for care. And I started to notice in my own personal journey things that were paralleled in the conversations we were having with caregivers. So we knew that caregivers had these pain points and we knew that we wanted to address them, but we didn't necessarily know how we wanted to address them. And then it was a full year later after that that I started to realize that, clinical care was helpful to an extent, but what really helped my recovery and my wellness were the relationships that I maintained in my life and feeling supported, feeling uplifted, completely doing a 180 on sleep routine, habits, stress, eating. All of this was critical for my recovery. And that's when we as Psyche started to turn and redirect and say, look, there are ways that we can uh, create new interventions outside of traditional clinical support, still evidence-based, still supported by clinicians, but delivered by an alternative type of provider. And maybe focusing on this type of intervention can actually move the needle for families. So it wasn't necessarily one conversation or one aha moment. It was a slow development and transition to wellness for myself that allowed us as a company to really take a courageous step forward and saying, hey, we don't want to just create additional access to a system that wasn't necessarily helpful for me or for my co-founder or for others that we interviewed. We wanted to be able to, from scratch, build up an intervention that we truly believed in because it focused on relational health in the home.
Yeah, I think that's a powerful insight. And, not only from your lived experience, I know you and Hun Shao, in those early days, taking kind of the family perspective, taking the kids' perspective, really naming the relational aspect of this, the holistic aspect of this work, and stepping out of what the system sort of typically orients around was a huge insight. And it's beautiful how you wove all that together.
So, Mallika, we've gotten to know a ton of the promising interventions in this space, and it feels like the default move for tech-enabled mental health platforms right now is to put a clinician in the center. That's you'd understand why. I have no problem with that. But you and your team at Psyche chose to put a parent at the center. Can you tell us a little bit about why and what did the data, the families, and your own experience tell you about that and made you feel like that was the right call?
Definitely. And it is important to state that both me and my co-founder have not previously worked in the mental health field. I started this as an undergrad. I was studying engineering and I was personally motivated because of my chronic illness diagnosis. And my co-founder was a developmental psychology PhD student who was also facing similar challenges with her own family. So maybe call it naivete, but we really started with a clean slate of what we thought could be particularly impactful. And we both had training on disciplined entrepreneurship. And one of the core tenets of that is really listening to the end user and finding out what their core pain points are. So we weren't necessarily looking at here's the system or here are the interventions and here are the limiting factors with the interventions. We tried to say, hey, for the communities that we wanted to impact, what do they feel? And this could be completely outside of the clinical supports that they're already accessing. We just wanted to go in with absolutely no assumptions about what caregivers truly wanted. And when we were talking to caregivers, it wasn't necessarily that they wanted therapists. They weren't saying that they wanted extra access to therapists. If anything, we were talking to parents and legal guardians who have been through this journey for 5, 10, 15 years, who have become exhausted with explaining their story to clinicians that don't get it, that point the finger back to them. They just said that they wanted to feel heard and to feel supported. The only options that they had to feel supported were to go to Facebook groups of other parents who have been exactly in their shoes before. And we started to notice that pattern. Caregivers truly trusted individuals who have been there before and wanted to hear what worked, what didn't work, and things that they can actually try in the home environment to keep their child under the same roof and to prevent institutionalization. So when we came back to it, and we know that there are limitations in our model, and it's easier to get reimbursement if you provide a clinical service, and it's easier to get in the door with payers or stakeholders when you have the clinical service. We knew that we would have something successful, something implementable, something scalable if we truly built for the end user that we were hoping would opt into the program. And I'll add a caveat, it is still critical to involve clinicians, involve providers, involve these stakeholders, because this is not a solution in isolation. It's not that we just go find caregivers and we offer this program. We have to integrate into hospital systems and we have to sell into payers. So it has been really important to involve clinicians in reviewing our curriculum and supervising our peers and just have an added voice to the table in anything that we do. So it's not necessarily that we've removed a clinician's voice entirely. That's not at all the case. We're still anchoring on evidence-based tools and having clinicians inform our product development. However, the way that the product feels, takes shape, and is delivered is truly informed by a caregiver experience.
And I love this sort of, basic but critical insight that you had, and coming at it from a beginner's mind, not being from the clinical world, of go to the people directly affected by this, learn from them, build for them, and be open to the challenges basically that you opened yourself up to of not being clinical. And now you're not fully on the other side of that, but you've been able to navigate and deliver for many families. Can you share any lessons learned about how you've taken this, the non-clinical solution, but anchored in serving the people we all want to serve? How have you been able to make it to the other side, or at least start to make it to the other side and start to serve more and more families?
Yeah, definitely. And maybe just a quick anecdote to share, like how my personal experience has informed the implementation of product. When I was going to ER visits and being discharged and told that there were 2-week, 3-week waiting lists to see a specialist, I didn't know what to do. And I was frantically Googling and trying to figure out next steps. And when I felt like I wasn't heard by specialists, the solution to my challenges was not necessarily let's go connect you to a specialist tomorrow. It was, who else is out there that's been through what I've been through that can tell me what to do right now as I go back home? And we're noticing the same thing with caregivers. We spent a full year just interviewing parents, legal guardians, parents, or caregivers, adoptive parents, to understand what are the thoughts and feelings that are coming up for you as you're transitioning out of an emergency room. Where are you turning? We don't want to completely reinvent the wheel. We want to meet a caregiver exactly where they're at. So we spent a lot of time just mapping the thoughts and the feelings of caregivers and made sure that we specifically tailored our verbiage to ensure that caregivers felt like we were someone that they can trust and um, someone that they want to try, or a solution that they wanted to try. We know that this space is incredibly stigmatized. To parent a child with severe emotional disturbances is incredibly difficult when you feel like you should know what to do as a parent, but it's an unforeseen challenge and it really is complex. So to get in the door in this post-crisis moment was really important for us because that was a moment where we noticed that caregivers were a little bit more receptive to trying out something new, especially if they've been exhausted by the system. And that first session that we deliver is incredibly critical because we have to make sure that the caregiver trusts that we are a service that they want to try out, that they feel like they leave the call with something actually actionable and practical, and that when they implement it, they actually see immediate results. And therefore, we've really focused on not using the first session to say, this is what Psyche is going to do for you in the next 4 months. It is, what is Psyche going to do for you right now in these next 60 minutes? And then we'll figure out the next step in the next call. And that has actually translated to incredible uptake metrics where every single family that has enrolled after intake has completed our program. We don't have drop off after we have the intake and enrollment. And we're seeing that that in itself scales. So instead of us going to 5, 10 sites of uptake and missing 50% of the families, we've really tried to focus on, okay, at these 1 or 2 sites of uptake, how do we make sure that we're capturing 90% of eligible families and converting, as high as we can on these families that we believe we can serve. So we've taken this slightly slower approach in the way that we're expanding. And we really stick to our guns on the fact that we want to be able to capture all of the families that could be eligible. And if we are missing families, how can we tailor the verbiage? How do we make sure that we offer the right skill at the right time so that they actually see the value and they want to retain the service?
That's amazing. Thank you for sharing that with us, Mallika. I want to take it to the experience of a family in crisis. So walk us through what happens to a family the day they leave the emergency room or inpatient unit with a kid who's in crisis. What's the gap you're walking into? Tell us about the experience that a family is going to have in seeking care with Psyche.
Yeah, definitely. So we've noticed one of 2 journeys typically for caregivers. The first, which is the most common, is it's still an ongoing crisis. Caregivers are going home, and it's not like going to an emergency department was of much use. They go home, they know that they're on a wait list for care, or if they already have a therapist, they're waiting another week or 2 weeks to see their clinician. But they're still fearful of having the child go to bed or wake up in the morning and not know what the next steps are. They're fearful of what's going to happen to the rest of their kids. Can I take the rest of my kids to school the next day? Like, what do I do? And what happens if something like this happens again? I've been to the ED 3, 4 times in the past 6 months. Like, this is going to be a cycle that recurs and happens, consistently. So that tends to be the main bucket of families that we see. And then we also see what we tend to call a honeymoon phase where, oh my gosh, like, I'm relieved that we are at this end of crisis. Like, let me take a break. It's been a chaotic 24, 48, 72 hours. And I just need to slow down. And maybe we see 1 or 2 weeks of this calm down or cool down phase, but inevitably there will be another escalation in which the caregiver is once again thrown into crisis and doesn't know what to do. To the point that we made earlier about the stigma and, making sure that there's an open door, we see that there are differences in the ways that these 2 groups of families might interact with us. If there is immediacy and there is that need, we tend to see that caregivers might uptake the service as early on as being in the inpatient program itself, or maybe directly in that transition. Or we might see caregivers that initially are interested, they're curious, they may not uptake initially, but in a week or 2 weeks' time, they reach back out and say, oh my gosh, I'm in a moment of crisis. What do I do? And yeah, these 2 camps are typically what we see. And the way that we address the gap for them is we offer something that is relevant and immediate, which in the system currently, it's usually that it is relevant or it is immediate. In terms of immediacy, you can go to an emergency department, you can call 988, but maybe you're not getting the right support. And for something that's relevant, you're waiting weeks and weeks to see a psychiatrist or a therapist or any sort of clinician. So we don't say that we're replacing clinicians once again, but we really offer the support to say, okay, as a parent, what do you do as you get home? What is the safety plan? In what case do you actually escalate to an emergency room versus what do you think you can actually handle in the home environment? What are these triggers that exist in the home for your child? How do you navigate this with the school? Like, how do you get additional accommodations with the school? How do you communicate this with your other children or your partner? All of these very practical steps for the home environment, that's exactly the gap that we fill. Typically, families will have to turn to Google or Facebook groups to figure this stuff out, but we really streamline it such that you have your 1 hour session with a family peer and you have the exact next steps for what to do in the home environment, how to safety plan, and how to have a protocol for crises.
Well, and the examples you shared, it's so powerful because I love the relevancy and urgency frame, but then it's comprehensive and not clinically comprehensive, but life comprehensive, right? Just those examples. What about school? What about like when do what? Like those can't be filled in with one long sheet of paper, right?
Definitely. And I think one of the initial pushbacks we got from stakeholders when we were building for caregivers is parents don't have the time for this. So why would you build for parents? Which I think is a faulty assumption. It's maybe we haven't been building something that is actually tangible and useful for all of the balls that parents have to juggle on a daily basis. So I think that's been the benefit of listening to caregivers. It's yes, like my child's wellness is at the core of everything that I do, and I want to make sure that they're better, but I have to juggle work and the other siblings and my partner and all of these other components of life that really contribute to, all of this chaos. So how do I just get that all under wraps for myself? And one thing that we find critical, we are focused on relational health. We're focused on the wellness of the child. But what comes first is that the caregiver is regulated and the caregiver feels supported. So we often say, like, put your oxygen mask on first before going and supporting others. And it oftentimes might feel counterintuitive, but that's how we start our curriculum. It's let's get the caregiver in a position and a place where they feel very well supported and they know what to do in all of these facets of life. And then we can start thinking about the next challenge.
Yeah. Mallika, I want to ask you about your go-to-market strategy, but I actually first want to take a step back because you quite literally went to markets, right? And when we talk about the entrepreneurship journey, there's so much that you can learn by reading research and talking to people who have done it before. But there was a point in your entrepreneurship journey that you were like, nope, I actually need to go somewhere. And so tell us about your decision. Tell us where you went and your decision and what you learned when you literally went to markets.
Yeah. So this is something that we started doing as early on as like month 1 or month 2 of us researching for this company. And we had this advisor, after sharing that we wanted to work with emergency departments, he said, well, why don't you just go to an emergency department and talk to a social worker? And I didn't know that you could do that. So then I just left my apartment and I walked 20 minutes down the road and I entered an emergency department in Cambridge, Massachusetts. And I walked in, I said, hi, I'm a student. I'm doing this project and I would love to talk to one of your social workers, and immediately got a phone number for one of the social workers, as well as, the clinician had a nice conversation with me. And that's what really lowered the barrier to entry for me to say, okay, I'm just going to go to where the people are at and ask questions. And it wasn't until a full year after that where I was sitting here in Dublin, California, calling clinics in Minnesota, where it once again occurred to me of, oh my gosh, no, I need to be on the ground. I can't be doing this calling. Not everyone is on LinkedIn. Not everyone is going to be responsive to emails. I just need to be on the ground. So, going back to also the thought about go to market, one thing that's interesting about us as a company is we have payers, right, which is traditionally insurance companies, and we have our end users, but we don't forget about all of the implementation partners because there are also people that we need to sell to. So when we were thinking about going on the ground, we were saying, who do I want to target? Not just the clinics, but the specific persona at these clinics. What do they want to hear from us? And how do we build rapport quickly? So I knew that when we were going to clinics in the community, we were mostly going to be targeting practice owners of outpatient mental health clinics and primary care facilities who are serving a large population of pediatric patients. And I knew that a lot of these individuals were probably older millennial, really cared about, serving youth, loved smaller, cornier items. And therefore I was like, oh my gosh, yes, I have to add small, corny items to a gift box and, hand deliver them. And, maybe that's going to add to receptivity. And I also packaged what ended up being a crocheted pickle, emotional support pickle, as well as a candle, with some stats on what Psyche is and what we do. And I lived with my co-founder Hunxiao in Minnesota for about 3 months, and we rented this Jeep on Turo. And every day I was delivering these boxes to whatever clinic I could find. And it was a lot of just sitting in waiting rooms and just sitting in the Jeep. But ultimately, as compared to me sending 100 emails from Dublin and getting 0 responses, sitting in the waiting room for 2 to 3 hours and getting to talk to someone and then getting to talk to the practice owner was a lot easier. And so, yeah, it's become kind of a core part of our success. And actually one of my favorite parts about building the business is getting to know everyone that's on the ground. And the beauty of this too is, oftentimes if someone doesn't really find your solution to be helpful or important, they won't respond to your email or they won't pick up your call. But when I had them right in front of me and they didn't really align with what we were building, I got feedback immediately. So every day, even if I wasn't getting a partner on board, I was learning something new at a rate that was a lot quicker than me sitting behind my laptop in Dublin. So it's become, core for what we're doing. Hunxiao went over to Maryland, to MedStar, to talk to all of the discharged staff members on the ground to see how they're currently integrating or implementing services in their workflow and how we can tap in. And, we continue to call and touch base with everyone in Maryland, and, we're flexible for location. So once again, like to the point of naivete or being early in the field, we've really made no assumptions as to how these clinics work and who we should talk to. And we just entered in and knocked on doors, and it yielded some success, which we're really proud of.
No, this is the most important piece of feedback that you can share with entrepreneurs. I was going to ask you like what it was, the corny item that my generation wants. And I own an emotional support pickle. Like you nailed that. I do have one on my desk. I love that. Mallika, I remember talking to you when you were in Minnesota and you're like, we're trying to do it before it gets too cold here, right? But just like your commitment to going to where the people are, listening to their unmet needs and then designing with them at the center is just so important to drive home for all entrepreneurs. But then you were successful, right? You sold to the hospital discharge teams, which in general go-to-market strategies is one of the hardest nuts to crack for the sector. So what did the first ER team need to hear to say yes? How are you doing it? How are you able to scale? And once you build those relationships, turn them into transactions and sell?
Yeah, definitely. And what's interesting is we are now in a variety of sites, right? So we're in outpatient mental health clinics, we're in emergency departments, and then inpatient programs. And as mentioned earlier, we really have to treat these implementation partners as additional sales. And the reason for that is the metrics of success for these partners are completely different from our end user or ultimately insurance companies that tends to be our main payer. So when we initially started going to emergency rooms, I think in 2024, we rented a car and tried to drive across Connecticut and just hand out flyers to emergency rooms. And we got no yield. No one was handing out flyers. We weren't really getting uptake. And we were trying to figure out, well, why exactly is that so? And there were a lot of questions that popped up initially of, it's the wrong purse problem or the misalignment in healthcare that everyone talks about. The managed care companies that are really excited about our service want to pay for it because we're reducing emergency department utilization. But is this actually advantageous for an emergency department that generates revenue from these sorts of visits? So we started to have some doubts initially, and it took a lot of curiosity from our end for every single one of our implementation partners, define what metrics actually mattered to them. What was really interesting for the emergency department is, if we're focused on discharge staff members, they're not particularly incentivized to refer to a peer support program when maybe a psychiatrist or a clinical service is something that they'd rather prioritize, right? So that was a huge roadblock for us initially and took a lot of question asking on the like key decision maker front to say, well, where exactly in the emergency room can we actually fit such that everyone is really excited to refer to psyche and we actually are capturing every single family, as mentioned earlier, right? Like this is why we pay so much attention to these metrics of success. It's we want to be able to capture every single family that is eligible for the service. We start to find out that, okay, at the emergency department, it's not necessarily referring to a parent peer program that's going to render success, it's reducing the length of stay. And a lot of times when parents don't know what to do next, they don't want to take their kid home. Right. And we started to learn from our partners in Maryland that this population of pediatric behavioral health is actually, it ends up being some of the hardest to place patients because parents don't know what to do next. So it's a really top of mind problem. So then how do we reframe the way that we pitch this to hospitals from being an additional support service and discharge to something that can actually move the needle on length of stay? So then we're now playing around with what does uptake look like? Can we uptake families faster in the emergency department? And this feels like an entirely different product than what we had built before, but it ultimately aligns every single stakeholder that we have here. We really built a program that caregivers love using, and that's why we see the uptake rates. That's why we get excitement from the payers. It's because we align our metrics of success with the payer model. And then also on the implementation side, we're seeing that hospitals are excited to implement us because we're moving the needle on metrics that matter most to them. So just to wrap that all up and tie it with a bow, being able to define what is the motivation for any single person in this continuum to get excited for our program, and then retailoring or rebuilding parts of product to align with those metrics is what has really helped us in moving forward. And we're actually testing out an idea of an ED kiosk, which would be a kind of workstation on wheels in the emergency department itself, such that we can capture families earlier than discharge. So this is still a work in progress and it's ongoing, but it's super interesting to notice how different the metrics of success are across the system, but then knowing that there are bits and parts of our product that can be tailored to each one of these stakeholder challenges.
Yeah. Thank you so much for sharing both versions of the go-to-market strategy. Before we jump into fundraising and the gas that your Turo Jeep needs to run, right, to have the impact that you want it to have in the world, can you talk to us about how your involvement in the Thrive Center Fellowship helped map that evolution, right? It's you. I mean, upon my first meeting with you, I was like, Mallika's going to be successful no matter what she does, whether it's as a comedian on stage, whether, as a poet and as a mental health disruptor, you're going to be successful. But can you talk a little bit about the inflection point at which you did this fellowship and if it made a difference, and if so, how?
Oh, yeah. No, it made such a huge difference. And once again, both me and Huncho not having clinical experience, we don't know how clinicians operate and we didn't know how to even enter. And everything we did up until that point was scrappy. And I mean, we're still a scrappy company, but what that means, at least for before the fellowship, was we were uptaking families from Facebook, which was not super sustainable. It wasn't scalable. It wasn't repeatable. But that was the only way that we can learn. And we knew from all these caregiver interviews that we needed to go to emergency departments. But as mentioned from our Connecticut story, like we could not find a way to break in and we didn't know how else to do it. Being able to join the fellowship with a network of advisors who both have the research experience, but connections back to the hospitals and just the translational medicine side of it was really impactful because it first and foremost gave us a sandbox to explore, to call and talk to people. How should we be approaching the ERs and the inpatient programs? Are there specific words that we should include, verbiage, the way that we tailor, the way that we pitch this, specific flyers or materials? Like, how should we approach this? Having the few months to just test that out and then have the connection back to the hospital system to say, okay, let's try this. So we were able to actually connect to MedStar Health System from the Thrive Fellowship, which really extended our work that we did in the fellowship, which was mostly focused on uptake from emergency departments and inpatient programs. And we were able to connect with a fabulous champion at MedStar who was so excited about the work that we were doing, especially having heard all of the progress we had made in the fellowship. And we were able to implement at one hospital site at MedStar Health System. We had a goal of, working with 10 to 15 families, which we've exceeded since the start of the kind of partnership or pilot. And we've been uptaking families from the inpatient program and the emergency department. And we're seeing that a lot of those learnings from just calling people and interviewing and having that sandbox in the fellowship are translating into this real world translation of our program. And we're seeing that about 85 to 90% of eligible families are, able to even have the intake call from the inpatient program at MedStar Montgomery is the hospital that we're at, which is incredible. That means that we have the inpatient staff on board. They know when to refer families. They have a Calendly link. They're able to schedule, and we're not missing that many families in actually referring over to our service, which has been incredible. And I don't think we would have been able to make it to this point had we not had the sandbox to really explore what it means to be in an emergency department or an inpatient program.
The the sandbox may have been supportive, but as with everything you all do, it's just the energy, the curiosity, the anchoring and being relational with the families, with the partners, is you always take things to a level that's just inspiring and energizing. And one other sort of topic we wanted to cover before we start moving towards how do we get our wonderful listeners to help bring psyche to more families is you all have taken an approach on fundraising that I think is like really, thoughtful and oriented towards making your mission come to life in the most effective way possible. That is easy to sort of articulate, I think, on paper as an approach to take, but there is just this sort of standard: go raise VC, go big, if you believe in what you're doing. And you all took a different route. And if you don't mind, I'd love to hear a little bit more about how you thought about raising money and how that has come to life, and any lessons learned you might share to mission-oriented people who want to build big, ambitious things.
Yeah, definitely. And I think at the core of my concern with VC or the thoughtfulness was this idea that big is subjective. Everyone wants to build something big, but what that actually means in translation can vary so heavily from founder to founder and from business to business. And I went to a very tech-heavy school, and when I saw friends starting companies, especially maybe your B2B SaaS or AI companies, they were seeking metrics of success that were very different from what we really wanted at the core of our business. The Silicon Valley catchphrase of moving fast and breaking things doesn't really apply when the things you would break in this space would be people and their wellness and their mental well-being. So I knew very early on, even before starting Psyche, that for healthcare and VC to go together, there needs to be a very clear pathway to whether it's $100 million or $1 billion in a certain time frame. And I knew that I wanted to build a Medicaid business, and this time frame may or may not be conducive to the longevity of our program. We also know that a lot of the successful VC-backed digital health models ultimately are taking these evidence-based collaborative care in-person models and maybe translating it into telehealth, right? And we knew that for Psyche, we are taking a step behind that and saying that this intervention that has been underexplored is impactful. We knew that that was going to take a little bit more time up front. Maybe, the space would not be as receptive to it until we started building up that evidence base. And we knew that the barriers to entry for us would be very different from other innovators. And we also knew that this was going to be a long-term project for both founders. Relational health is something that from personal experiences we've both come to learn is the most important guiding force in both of our lives. And we want to make sure that this company can be sustained in the long term versus whenever the VC money runs out. So early on, we tried to say, okay, what is a realistic timeline for us? What's the realistic size of the business? What do we actually want to build here? Do we want to build a business that exits in 7 to 10 years, maybe faster now with everything in the AI space? Or do we want to build something that we can continue to reinvest in over time, might be 10, 20, 30-year project, but really gives us the space to play, grow, and own the work that we're doing and what we want to explore on the relational health side. So for our pre-seed round, we knew that we probably didn't want to go down the VC route, especially as we were exploring and trying to find our footing. And we actually found a family office that invested a $500K safe. And the person who runs the family office is incredibly mission aligned with what we're doing. He has been an entrepreneur himself. He knows what it takes to start a tech-enabled services business. And he's a parent and he's seen these challenges firsthand with his own family. So having someone that really understands the mission, understands what it feels like to be an entrepreneur, and knows that for a business like this, the timelines might be a little bit skewed and what success looks like is very different was incredibly impactful. And I'll also say, like, both me and my co-founder are young women of color, in our 20s, first company. There's certain sorts of capital that are more conducive to the sorts of business and then the sorts of founders that we are versus the traditional VC route. So being creative and being really thoughtful about capital has actually been really supportive to our business. And I can't imagine what it would have felt like had we raised a pre-seed round and been held to certain metrics of success on a certain time frame and not had the space and time to explore. We've been able to be so thoughtful and methodical in our development and our implementation just because this is the sort of money that we took. So, whether or not that stands for the next rounds, we're not sure. And we don't know what sorts of money we're going to take when we de-risk the business more and we know what's working and what doesn't work. But at least for us right now, this made sense. And I'm all for alternative forms of capital. We knew on the other side, a lot of people say maybe you should fund with non-dilutive for the first few years, but with all the cuts to SBIR grants and other federal grants, it just didn't make sense. So the family office capital came at the right time for us, where it really gave us gas in the tank, where non-dilutive funding just could not, and VC funding would put an additional inherent pressure on us with, So this was just perfect. It was a sweet spot for us.
Yeah, you aligned your funding strategy and the funding partner with your long-term game, which is changing lots of families' lives for the better over decades, not over a 20% month-over-month growth rate near-term framework. And that's beautiful. And I think this insight on family office, but also somebody who knows the entrepreneurial journey, because I think that like having those two together is a really powerful, you hit on it, is really powerful. That empathy, the sort of support they can give, the understanding of the pressures you're feeling is really a nice combination.
Definitely.
And so shifting now to activating the Thrive community, we have two final questions for you. One is, for a parent who may be listening, who just brought their kiddo home from a 72-hour hold, what do you want them to know by the end of this episode? And what should they be thinking about doing in the next 24 hours?
Yeah. First of all, just recognizing the incredible work that this parent has done in navigating the system. These are completely unforeseen challenges and really complex problems that people don't really know how to address. And there's very limited visibility in the next steps. And it truly is a journey, and it takes you on ups and downs. And, just being able to recognize the amount of work, emotional labor and time, and, everything that a parent has to take on in order to navigate all of this, just acknowledging that, first and foremost. Then the second thing I would say is there are options, right? And you got this. There are ways that you can navigate these challenges at home. And you have all of the tools in your toolkit to do that. And we're here to enable you and to guide you in figuring out what is actually most important for your family. One thing that we realized with Psyche is we're not prescriptive. It's not that every family needs to follow some core tenets for success, and therefore they're going to, prevent ED utilization or prevent escalation of care in the future. We really keep parents in the driver's seat. And we're here to guide them towards the goals that they believe are important, especially when you're juggling so much. We're here to separate what's critical right now from the noise. And you have everything in your power and currently in your toolkit in order to do that. You know what's most important for your family. We're just helping you put pen to paper on that. So having a protocol, the guidelines, something to fall back to, something to anchor you to, is really going to be supportive in the journey. And the ED is not the only option if, you're looking for support or for guidance. And the Facebook group is also not the only option. There are supports for you that exist, and we're here to help you anchor to those supports, define what protocols look like for you, and define what success looks like for you. And then finally, this journey can feel incredibly emotionally taxing and tumultuous, and oftentimes there's no space to celebrate successes, but you have the entire you have all of the space in the world to celebrate successes. And I hope you know that there are so many of us celebrating with you, whether it is the small conversation that you had with your child today or the laugh that you shared with your child. Like these are all such small but beautiful successes that I hope you have the space and time to celebrate with your family, because these are the simple joys and this really keeps moving all of us forward, right? So being able to acknowledge and give yourself the space and time to celebrate successes, I think is really critical.
That's so beautifully put, Mallika. And both Jason and I are parents, and we know that the best parts of parenting come in those small moments, right? Of those celebrations. And so I love the hopeful and aspirational approach that you take to something that is so often painted as a foreboding, looming mental health crisis, right? And like, absolutely, young people are struggling in many ways. And they themselves, their parents, their peers, their communities have within them the resources and relationships and connective tissue and social capital to help save lives, right? And that the fact that PsycheCare reinforces that so beautifully is just a real gift to the world. So,
Definitely.
oh, go ahead. Were you gonna add something?
Yeah, just one quick note.
Please.
It's really easy for us, especially in these spaces, to get caught up in, what does it mean to be sustainable for the business and what are the metrics of success? But truly, when we come back to caregivers and we hear how everything's going in the home and, what's been happening and the impact of psyche to their worlds, it's always these smaller moments. It's, for example, one of our caregivers, her car broke down on the side of the road when she was with her daughter one day. And this typically would have been a moment of escalation and, an argument, but ultimately it turned into like a really fun conversation for the entire kind of walk back home. And they were laughing the whole way through. And it's truly a testament to the fact that what's important for families is completely different from the system, but this is what we're trying to build for. It's to celebrate these successes and to uplift these stories that, this caregiver never thought that she could share a laugh with her daughter again after everything that they've been through. So, we really want to hold these at the center of what we do. And we truly believe that that's what's most important because it's what's most important to the families.
Yeah. And you do it beautifully. Let's in thinking about how to help you build more. Let's end with a question for a hospital system or a payer or a funder that may be listening, right? Jason and I know a lot of well-resourced people that are looking for their next big bet. What's the door that you want them to walk through, and what do they need to hear from you to walk through it? What's your invitation to folks that can help you build?
Yeah, like we've taken an incredibly clean slate approach, and it has required a lot of courage, especially in a moment like this where Medicaid is getting cut left and right. But what we know is it's just going to be exacerbating the problems for families and what they face, as well as the toll and burden to the system. We're going to be seeing way more families coming into emergency rooms. We're seeing the year-over-year growth rate of pediatric, behavioral health ED visits just increase. And these are families that typically do not get services tailored to them. These are the families that are hardest to serve, that a lot of companies turn away because the child is suicidal or self-harming and they just don't know where to turn. And we decided we wanted to get into the smack middle of it. And we really wanted to take a big risk, a big swing here and say, we think we can serve these families. We can truly impact these families. And with the results that we're seeing incredible progress. And this is something that can be scaled across the country. I'll give an example of one of our cohorts. So in a small group of 20 families that were being discharged from an inpatient program, they saw 54 emergency department visits and 294 inpatient days in the year prior to using Psyche. And we've been tracking them since the completion of using Psyche. And we've seen 5 ED visits and 24 inpatient days for this cohort. So an incredible reduction of service utilization. And, unfortunately, it is through these metrics that we have to communicate that this is something that can be impactful to families. But ultimately, this is what gets us in the door. It really aligns with these core metrics of success for the payers, for the health systems. And it's incredibly scalable. We're hiring peers from communities that understand what it feels like to go to this hospital and access these resources. So ultimately, this is a big swing, and we're already seeing early success. And we cannot wait to continue expanding this because we're hearing incredible stories from parents and families that have now reinvigorated their hope for the direction of their family and for their children. And we just can't wait to do that for every family across the nation that needs a service like this.
That is, I think, a wonderful place to end. And just thinking about that should open up so many doors with providers, for payers, for families. And Mallika, we just want to thank you, first and foremost for spending time with us and sharing your story and the impact of the work you all are doing. But just the passion, the brains, the energy, the moving all over to any place to be with families, to be with providers, to bring this important work to life is just so grateful for you and the work that you all do. And I think this, like, one big takeaway for me is this approach that you've taken out of, maybe the textbook of how an entrepreneur should build and actually bring it to life in a relational way. Everything you do, everything you and your team do is relational to families, to providers, and you're doing that in service of delivering a relational innovation for kids and families. And it's just I think a very not only inspiring story, but a very informative one for people who are trying to make change in those worlds. So thank you very much.
Yeah, and it's a lot easier for us as founders to live our truth, especially in a system that doesn't necessarily reimburse or prioritize our work because of spaces like the Thrive Center. And I really like Audre Lorde's writing, and particularly the essay "Poetry is Not a Luxury," and specifically the points about sharing in kind of the communal emotions and then bringing words to the experiences that really call people in for the thoughts and the feelings that tend to go under supported or under communicated in the larger community. And I really think that the Thrive Center lives by that. Its relational health has been, under tapped into, and just being able to put this mission out into the world calls so many incredible innovators, advisors, and communities in. And yeah, I'm incredibly grateful to the Thrive Center because it allows for us to feel just all the more confident in the work that we're doing.
Thank you, Mallika. Such a pleasure to be with you. And we can't wait to see you near a hospital or health system soon. So come get coffee with us when you're visiting an ER in our neighborhood.
And I'll bring another pickle for you, Maya, for sure.
Yeah, bring the pickles.